So this next session, we're going to concentrate on education contributions from the 4 countries. So as educators, we really enjoy this session, hearing from our colleagues across the countries about the work that's going on. So I'm delighted to be able to hand over to 2 of my colleagues from Scotland, Corinne Mullen-Mackay and Margaret Swankie, who are both nurse consultants in NHS Tayside. Thanks, Corinne and Margaret.
Good afternoon, everyone. My name is Karine, and I'll let Margaret introduce herself.
Hi there, everybody. I'm Margaret Swankie, as you heard.
Thank you for allowing us to present our very early findings of a research project that Margaret and I are both involved in alongside our University of Dundee colleagues. We wanted to understand the experiences of ANPs within a primary and community care setting in making onward referrals once they had clinically assessed their patients. The CNOD paper refers to ANPs as being highly educated registered nurses who manage the complete care of patients, and in particular there is reference to community and primary care ANPs in being able to onward refer and carry out investigations. Now, both Margaret and I have worked acute and community and primary care, and we currently work in a community and primary care background. Whilst both acute and primary care community contexts have significant challenges, there are different challenges for our ANP service within a community setting. And often the ANP is the first point of call for urgent care, and the decision making is often made without the support and infrastructure that is more readily available in an acute setting. For us as ANPs in that setting, it also feels like it's actually gotten worse since the pandemic. However, we're both very conscious of our own interest and our own bias, so we were very careful in selecting our methodology when we went to do this study. So what we did was we used focus groups, and sometimes that's seen as less favourable in research, but for us it was important that our ANPs felt they were part of a group and had that opportunity for that collaborative conversation and discussion in a way that interviews, for example, would possibly not be able to give us. It's also a very safe and supportive environment, so we wanted them to feel free and being able to actually say exactly how they felt. In terms of studying professional practice, focus groups is also a very positive way of doing this. And one of the things that Margaret and I feel really strongly about is being able to hopefully use our findings to influence the development of the ANP role within a community and primary care setting. Our sample consisted of 5 ANPs, which gave us 1 focus group, so it was a very small sample. Now that took place in April of this year, so it's still very early. This involved ANPs from both GP practice, our community mental health team, and our peripatetic care home visiting team. The experience ranged from being newly qualified to over 10 years, and they came with a background of district nursing service, secondary care, and GP practice. 3 emails were sent out 2 weeks apart to encourage participation, alongside a full explanation of the research and participant information sheet. We're very careful with our ethical considerations, so the email was sent out by myself because people did not know me. We also secured confirmed consent, and confidentiality and anonymity, I've been practicing that word for days, was maintained at all times. The focus group was facilitated and audio recorded by our university colleagues from Dundee and transcribed. The data was collected using Braun and Clark's 2006 6 phases of thematic analysis framework. And Margaret and I both looked at the data independently of each other, and we put it into themes. And once we'd done that, we met up with each other again, and we went over our themes and shared our findings, and we refined our themes. We did this again with our university colleagues, and again further refined our themes. It was important to ensure rigour in this process and make sure that we were understanding properly. And in order to mitigate the risk of bias, we're going to share some quotes with you to support the findings, support the credibility of our findings, hopefully, that we hope to share with you. So the results are presented in 4 main themes, and there are sub-themes. Are you seeing theme 1 at the moment? Yeah. Theme 1 was in relation to preparation for the role. The ANP's experience varied in terms of referring patients onwards to clinicians, secondary care or admission to hospital. One of our community mental health ANPs described a really positive experience of referring a patient back into mental health services. But when it came to referring back to a GP, she found that very difficult and challenging, despite them demonstrating a comprehensive clinical assessment. The general ANP had described challenges in referring as an ANP, and yet had not had the challenges of referring as a DN. So for them, this was quite a relatively new experience. So this is quite challenging for them, having done it before. Education was another sub-theme in terms of the ANP's experience, and the consensus from the ANPs was that they felt really quite unprepared in the role, particularly for the questions that they were being asked, who to speak to, which pathway to follow, all of which had significant delay and stress on the patient journey and to themselves. I'll just go to the next slide. The next theme was communication. Again, it'll probably come as no surprise the IT systems were particularly challenging, despite the CNOD paper emphasising that we should be able to refer and ask for investigations supporting an autonomous practice. The NPs in our study reported really quite onerous processes where what they had to do was complete their clinical assessment, put it onto an electronic patient record, email the GP to say, could you refer this patient? The GP would then copy and paste what the ANP had written, send the referral off, and then wonder why the ANP couldn't have done that themselves. At no time were any of these referrals from the ANPs declined, so the referrals were correct. Verbal communication was another theme, and the ANP spoke particularly about the difficulties they'd had with trying to get their findings and the messages over in an IT referral template. So what they found was that verbal handovers were much easier, being able to convey the clinical assessment, the news and SBAR, which allowed for much more meaningful conversation, particularly around conveying findings of clinical concern, but also how that may have impacted on the patient's home circumstances. And I'll hand you over to Margaret. Thank you.
Thank you, Karine. So what the ANPs described in these focus groups were, sorry, I don't even know why I've gone there. Yes, a number of scenarios where their referrals, particularly when referring to arrange hospital admission, were met with challenges which we categorised under Theme 3, Gatekeeping. The gatekeeping theme related directly to professional challenges of the ANP clinical assessment and decision making. There were 2 particular groups of staff who were identified as giving challenge: the registrar or consultant in the receiving unit of the acute hospital and Scottish Ambulance Service staff who were contacted to take the patient to the acute hospital. The ANPs reported that even after providing a professional handover, using SBAR format, providing a thorough clinical history and clinical assessment of the patient, the admitting doctor would still sometimes ask if it was more appropriate for the GP to assess the patient first. As you can see from the first quote, this was not met with great joy by the GPs. Those who work closely with ANPs have great faith in their clinical assessment skills and feel no need to conduct a repeat assessment or have second visits to people at home. So these GPs would have to phone the admission unit to explain that the ANP assessment is thorough and correct and so should be accepted. This caused unnecessary upset and a delay in the process for everyone involved. This raises the question of whether, despite the number of years that ANP's roles have been developing, do we still have a culture where it's more acceptable to question the clinical decision-making of a nurse than it is to question the clinical decision-making of a doctor? What was also discussed were a number of occasions where ANPs had assessed that the patients were acutely unwell, had contacted Scottish Ambulance Service to arrange hospital admission, and the initial assessment had been challenged. Some of the examples given did relate to the ANPs not being aware of pathways available to arrange an acute admission without requesting a 999 ambulance. However, there were other examples given where staff had assessed that a patient was acutely unwell with suspected sepsis, and the transfer to hospital was declined, and the SAS crew handed back responsibility of care to the ANP. When these challenges were given, the ANPs felt that there was no consideration as to how the safe and effective care could be delivered in the community, and that the ANP felt wholly responsible for arranging some kind of alternative care within a very short period of time. This often resulted in them making several phone calls over several hours in order to agree a plan of care, and most often this was eventually arranging admission by another route. However, one of the ANPs reported that they just stopped making calls to the admitting doctor and asked the GP to do it themselves. So, it's no surprise then that theme 4 are the feelings and emotions felt by the ANPs when their clinical decisions and pathways of care are challenged. Firstly, the ANPs described their feelings of frustration and struggle when trying to access the IT systems, as we've discussed, and one of the ANPs actually reported that having the appropriate changes in order just to request an X-ray was the longest and most challenging process she ever undertook. Again, why was this? Was it another gatekeeping hierarchical challenge to the independent working of ANPs? As well as feeling unprepared for making referrals to specialists or for admission due to lack of education and lack of IT access, they also felt concern about maybe making the wrong decision. An ANP described discussing an admission with the hospital consultant and having imposter syndrome, worrying, what if I'm wrong, even though the person they were referring had a new score of 9 and was obviously very ill indeed. These referral discussions included a number of questions from the admitting consultant which made the ANP feel they were having to justify their clinical decision-making and their ability to refer independently. For those who visit people living in care homes, it felt even more challenging. Trying to arrange admission for someone, especially if they have a diagnosis of dementia, was even more difficult. With staff trying to be person-centred, having to fight even harder to express the need for hospital admission for an acute reversible illness. However, their tenacity seemed to win over, as they then reported to having challenges in their way, but they got there in the end. The patient was referred to whichever specialty or hospital the ANP had assessed as appropriate. As I've said, the ANPs described trying to do what was best for the patient. They often had really good knowledge of the patient, how they normally present, and how they knew there had been a significant change. Those who described having their referral for admission declined shared the feelings of vulnerability when speaking to family members, having to say that admission's not happening, and that's really not a way to instill confidence in the ANP or those they are caring for. Through the focus group, it was clear that the ANPs were trying desperately to do what was best for the patient. They were trying to be person-centred, but those efforts were in vain, and sometimes the enormity of that responsibility was really felt on their shoulders. So the ANPs described a number of negative feelings as a direct result of the challenges made to their clinical decision-making. However, despite all those negative feelings, the ANPs demonstrated empathy with their secondary care colleagues. They understood that balances need to be made when hospital beds are full and resources are scarce, but it felt like all the pressures in hospital are recognised, but the pressure of looking after ill people at home are not equally respected. When undertaking the literature review, we found very few studies looking at ANPs in primary and community care. We found only 7 which met the inclusion and exclusion criteria. 2 of the studies measured the length of patient appointment time, or the time of the number of consultations per ANP shift, so we're really just considering how much GP time was saved. One study stated that the NPs had to discuss any patient who needed an acute hospital admission with the GP first, and another showed interest in referral for investigations, but again only to compare referral rates between ANPs and GPs. 6 out of the 7 studies reported a lack of understanding of the ANP role by other healthcare professionals, as we discussed this morning, and one study suggested that this lack of understanding resulted in the reluctance of primary care nurses to undertake ANP training. However, the 3 studies which sought patient feedback reported really high levels of patient satisfaction, having their care coordinated by an ANP. So, as Karine said, this is really early days, but our recommendations will include addressing the lack of formal education within the advanced practice modules, having clear, locally agreed clinical pathways for referral to specialties and acute hospital admission, exploring the governance of peripatetic teams having access to Sky Gateway, and supporting other health professionals to have greater understanding of the ANP roles through GP lead meetings both in and out of hours, and liaising with Scottish Ambulance Service and working with local consultant leads. And most importantly, to ensure all ANPs are offered restorative supervision on a regular basis to deal effectively with the emotions of their role. These are some examples of how and where we plan to share our findings and recommendations. Thank you for listening.
Thank you.
Wonderful. Thank you, Margaret and Karine, for your perspectives of work going on up in Scotland. Thank you for that. It's with great pleasure now that I'd like to introduce you to Rhiannon Fox from Wales, who will be presenting her perspectives of advanced practice in Wales.
Today I've been asked to speak to you about my transition from trainee to ACP. I work within ABUHB, Gwent Frailty Services, currently as a nurse practitioner when I await my accreditation, hoping to go through panel for my advanced title now in the next 4 to 6 weeks. Everything's done, it's just through the processes, unfortunately. So the first thing I'm going to talk about are my personal challenges. I feel that one of the first things to talk about would be the fear and confidence that comes with taking that change. I've been working to an enhanced level now for many years as a nurse practitioner, and when I took on my masters, started working through my masters, I was very aware that I was crossing into that advanced field. However, the closer I came towards the end, it took up my current role as an AMP, as I said, awaiting panel, I became more and more aware of the advanced nature of my role, and I started doubting myself. I feel that this is a completely normal response, and if anything, it gives me a level of awareness that should always stay with me to be able to manage the risks and not step outside my competencies or my scope of practice. I mentioned the awareness of clinical governance and the abilities to manage risk for those purposes. And then it's taking on that level of autonomy. It's a big step when you go from enhanced to advanced, and nobody can really prepare you for it, if I'm honest. And then I say around the frustration of standards, and I think this kind of goes in line with everything that's been spoken about today, and I'll go into this a little bit further on more in my presentation. I mentioned the awaiting accreditation and annotation as a personal challenge. It's a frustration. I've noticed that I'm referring when I say annotation, I'm referring to when I wait for my independent prescribing to be annotated on the NMC. I mention this as a challenge because over recent weeks I found is that more and more I step into my advanced nurse role, that I have this inability to act upon my own autonomy, because I'll see a patient and then I have to go back and speak to a doctor and say, well, this is wrong, and I think we should do this. When I've done this recently, going into a new job, it becomes quite of a difficulty when you started working with new doctors that don't know you, and therefore this delays patient care. I had an incident recently where it took a couple of days for that prescription to be done, whereas if I'd been able to do it when I'd seen the patient, it would have been a smoother process for that patient and in the patient's best interests. Standardisation. So this, as I said, it very much follows on to everything that's already been spoken about this morning. I haven't got enough time to talk through everything, but first of all, I'd like to mention, so the HCPC in 2021 research found 80% questioned around the standardisation of advanced practice felt it should be standardised to provide a greater consistency in training and standards across advanced clinical practitioners. However, there was disadvantages included around costs of the registration, the multi-professional regulations of standards, and following this it was decided that HCPCs did not feel that there was a requirement for standardisation. We then continued into what was mentioned earlier, the field research that's been done by the NMC that are currently completing review regarding if they feel that there needs a regulation, and it's nice to hear that this is moving forward, especially as the NMC being my regulatory body. Health Education England have created the Centre of Advanced Practice. This process has created reassurance to employers, patients and carers, and allows staff to have a digital badge which is transferable between trust health boards. And it's been quite interesting to actually see the chat comment this morning that there appears to be a process where this comes out of your education with you, whereas here in Wales we have to go through panel and provide a portfolio to do that, which evidence, to be honest, a lot of what you've done within your training. And then Health Education and Improvement Wales have recently completed their review, where they've recently in the last 2 weeks launched the professional framework for enhanced, advanced and consultant clinical practice. This will hopefully be a step in the positive direction for things to come here in Wales, and it will be that kind of clear guidance more of what you need to be working to that advanced level. However, although across these bodies they are all considering the review, it still isn't to my knowledge that this is going to be rolled out on a national scale. And, you know, as I live in South Wales, I could go across the bridge and work in Bristol, but it wouldn't be that simple for me, even though I've got that qualification. So it's rather sad and disappointing from a newly qualified advanced clinical practitioner's point of view. So as I said, I work in an Iron Bevan University Health Board, ABUHB, and as what I've been advised by colleagues is that they are one of the leading standards within Wales for their process to ensure that you have the requirements to work to that level. So to explain, basically, within ABUHB, I'm not allowed to call myself an advanced nurse practitioner until I've gone through panel and I've been given the paperwork associated to that, and then with that comes when I'm appointed to be a band 7. These variations across health boards within Wales can impact staff morale, retention, progression. The Welsh Government have recently released the importance of staff progression within their pay offer. Now, when I read this, to be honest with you, it just rolled out a thing to me, well, we can't even standardise our bandings across Wales. So as I said, work in ABUHB, I will get my band 7 when I've gone through panel. Yeah, if from what I've been told to colleagues that work in Betws Cadwaladr, they're band 7s at training and then they're band 8 at qualifications. So, you know, we can't even put that standard approach into what band that job title gives you, let alone what a clear progressional opportunity would be for somebody coming from, as I said, so You know, you've got your clear thing, you qualify as a nurse, you become a band 5. We haven't got that when we progress up into our career, and I think that's something that's going to be a big challenge. However, although I feel that, you know, having to compile my evidence, put this portfolio to panel and go through that process to get that ability to call myself an advanced practitioner is frustrating, it does also give me a good opportunity to pull together that evidence and say to me, you know, you can do this, and be able to review myself from a novice to expert point of view. I know that it was mentioned earlier about how when you are newly qualified as a advanced practitioner that you are novice. I think that depends purely on your experience. When I've self-assessed, there's some areas that I consider myself expert in, because as I said, I've been working to that enhanced level for a long time. But then there's some that I'm definitely like, no, I'm not really sure about that one. So I think this is a good way of building my confidence and my awareness of my abilities. There are also other reasons why this is important. So why should we standardise? Why should we have this approach across the 4 nations? To allow for a clear clinical governance and clear lines for public regarding the healthcare professionals they are seeing. So I've got a little short story for you. So basically, back before I was appointed into the role I'm in now, I attended a GP practice for independent for an interview for an advanced nurse practitioner. When I was there, I was questioned if I needed additional training for minor illness management, and I found that I had to explain what my education had entailed, what I'd done to get to this point. And then when the discussion moved on to salary expectations, it became quite apparent to me that they were looking for an advanced nurse practitioner with a prescribing qualification that they wanted to pay a top band 6 salary for. And, you know, in terms of competition, most GP practices pay 8s. And it just clearly demonstrated to me that they didn't understand what an advanced nurse practitioner was, because this was the first time they were looking for one. So if the employer doesn't understand, then how is that going to be consistent for the public? And I just found that from there then, it made me think, when I go to see the advanced practitioner in my surgery, who am I seeing? Because I've always gone in with this kind of attitude that, you know, I'm seeing the person that I was aiming to be, and it might not necessarily be that. And obviously I know experience is very key, but it's still, I know Beverly said earlier, it's, you look at that person, you think, how much am I going to question you about your decisions? And I think that comes from the backing that you have in the first place. So for all the reasons I've mentioned above, of if the title's Enhanced Advanced Consultant Practitioner were unified in requirements and banding nationally across the UK with professional body regulation, I personally believe we could continue to safely and consistently build the growing workforce of advanced practitioners that our health service desperately require. And then we can work on the issues that have been brought up in the chat earlier about how people don't understand what we do. I walked in to see a lady the other day and I said to her, "Hi, I'm Rhiannon, I'm the advanced nurse practitioner. I'm here to see you today. How are you?" During our consultation, her husband rang and I said, "Oh, it's okay, I'll have a look at your drug chart." And then she's on the phone to her husband. She goes, "But I haven't seen a doctor in days." And then I found I actually had to explain to her that what it meant to be in my job role, because the public don't understand. They don't know what it means to be an advanced practitioner, especially our elderly, which is my field of working. And therefore, you know, we need to work on that as well. It's not just the regulation, it's the public understanding as well, to know what that means, because that poor lady had no clue that actually anybody had set an eye on her from a medical point of view, because she'd been seen by an advanced practitioner for the past 3 days. So I think if we can make that clear for patients, we can make it clear for colleagues, we can work towards being safer and more consistent for everybody. Thank you so much for listening and for inviting me to be part of the conference.
Wonderful. Thank you ever so much, Rhiannon, for your perspectives about advanced practice in Wales. We really appreciate that. Thank you. And now moving on with our 4-country approach, I'd like to introduce Chrissy Eads, who is a consultant radiographer from Cornwall. So over to you, Chrissy.
Thanks very much, Helen. It's lovely to be here. Thanks very much for inviting me. So I'm Chrissy, I'm a consultant radiographer in Cornwall at the Royal Cornwall Hospital. And I'd just like to talk to you about our experience of the three of us that have just become or recently become consultant radiographers. I'll briefly talk about examples of our career progression and how we got to where we were, the real significance of education and training. And I want to talk about the Agenda for Change job matching. We've talked a lot about the ambiguity within advanced practice. And actually, if I can outline to you about the Agenda for Change job matching with the really important points, it may clarify a few points. And then also I want to really touch on how important a job description is. So, as you can see from this slide, it's taken a long time for us as to become consultants. I applied in July 2018, and under our job matching policy, that process should take about 6 weeks once the job description has been agreed and put forward for job matching. So just to confirm, job descriptions and personal specifications should accurately reflect the required work activities within the service and not the personal attributes or work preferences of the post holder. So what I want to make sure to get across to you as the aspiring APs or the advanced practitioners is make sure that the job role reflects what the service needs, not what you're qualified in. What comes second is what you're qualified in answers those service needs within your job description. What was really difficult for us in the beginning is that my job description, it needed to be looked at by the service manager. That took 6 months. That particular person was very busy and couldn't review it, and therefore I couldn't take it forward for job matching. When I did, it came back as a no match because I didn't have the proper research element within that job role. What happens then is actually there needs to be open dialogue between the service manager and the HR partner is how that job description evolves. But actually the person who knows about that job is you, is the poster, yet you're often not involved in that. And it was very similar for Sarah, who's our head and neck sonographer. It took her a year and then up to 2 years to get her consultant post for the same reason. The research element was too scant. And then I've been trained in job matching. I now work in the independent sector evaluating job roles. I find it a very fulfilling role. So I was quite savvy as to what needed to go into job descriptions. My point being here that our consultant MSK role we put forward for job matching at the band 7, it came back as an 8D. That was never going to stick. So it was then backwards and forwards for Rowan to get back to an 8B role. So my point being the job description is incredibly important as to reflect which band you're going to go in. It was really hard for us, actually. The difficulties we had, and it's going to be the same for you, is there was lack of communication. Even when there was no news, this wasn't communicated to us. And when you are hoping, you're reaching the high of your career and you're told that, this process can take 6 weeks and actually it takes over a year, it's really demoralizing. There are several layers it needs to get to. There's the service manager. Because you're at the band 8 level, the service manager, then up to the general manager, and then it needs signing off by the exec board. As you can imagine, these people are really busy and it is not their priority. Okay, there was a lack of understanding between HR actually and the manager about the job matching process. Once you've got ambiguity, it just really slows down. And as I say, as the applicants, we are all treated as the third party, yet you're the best person to answer the questions. My advice there would be is keep emailing and saying, are there any questions that need answering? Is there any clarification that you would need? But not all sad news. I just wanted to say, you know, this is us now. The career and the education and career framework for radiographers says that there needs a patient-centred approach to advanced practice. And this is us. I'm Chrissy. I report 33,000 patients per year from cradle to grave. Sarah is responsible for 70% of all head and neck biopsies. She performs 224 biopsies per annum, is hugely influential in the lung cancer pathway and the head and neck cancer pathway. And Rowan undertakes 331 therapeutic injections a year and 17 biopsies. We're here in part to answer the shortfall in radiologists and really support those diagnostic pathways. And between the three of us, we really make a difference. So this is a little bit of a dry slide coming up now, but to just talk through the knowledge, training and experience, the freedom to act and the research factors of job matching. So there are 16 factors, but what's really important in advanced practice is the KTE and the freedom to act. Because if these don't match, no matter how good you are across the job description in all the other 14 factors, it will be a no match into that band. So you need to be very clear that band 7 is up to a master's level, so be very articulate about the education you have. And then the band 8A is master's level, ideally holding that, and then highly developed specialist knowledge. Now, band 8, as you know, is the only band that has the A, B and C for those very reasons that that specialist knowledge can be really vast, diverse and larger in scope for some rather than others. And that's why there is that variability there to put you into those A to C roles. The freedom to act needs to be very clear at the level 4 level. You're guided by principles. At the band 8 level, it's level 5. So you advise the organisation, interpret the policies, and it's based on evidence. So you often write these policies. Now, the research is really important, and this is where we fell down. Okay, to get a band 8, you have to be at level 4 or level 5. So that means if you are going through job matching, you need to be coordinating and implementing some research. If you're at the band 7 level, you're undertake audit and you'll be part of research, but you won't be leading on it. So for me to go from the 7 to the 8, I am now a principal investigator on developing artificial intelligence to look at the tibia in the under 2, specifically looking for child abuse fractures. I'm collaborating with Exeter University on that, and I've got a grant from the College of Radiographers to take that forward. So it is now a big part of my job role, therefore goes into my job description, therefore evaluates it to that 8B level. Just an example for you. And then I just want to talk a little bit about, I just wanted to say, hot off the press, these are the jobs that are available on the NHS website. You've got advanced clinical practitioner in respiratory for Great Ormond Street, and then you've got an advanced clinical practitioner in intensive care in Swindon. And as you can see there, the differences are between the band 7 and the band 8 are holding the ACP qualification or working towards it. It's just an example to show you the differences in the band 7 and 8, which may help give you clarity if you're doing your own job role. Sorry, I'll just... Now moving on to the job descriptions, level of autonomy and the level of influence that you have. And I just wanted to talk about why these are really important. So the job description is really important across the bandings from band 7 to band 8. It outlines to the organisation what the job role offers. It says exactly what you do and therefore are responsible for and therefore is part of your governance. This works both ways. So in my job description, it says that I can concentrate for long periods of time and I should be able to deliver as the radiology guidance suggests, between 30 and 60 reports per hour. If I can't do that on a regular basis, I'm not fulfilling my job description. And as a manager, if you're listening to this, this is somewhere where you can start and think about whether that person fulfills their job role. The level of autonomy is at the band 7 level, we're guided by protocol and national policy, whereas at the band 8 level, you may advise and are responsible for policy and protocol and writing, and you may advise regionally, nationally, and then as you move up the band 8, also work across interclinical and academic institutions and advise that way. The level of influence should be very clear within your job role. Do you work locally or are you part of a network? For example, we've got a Southwest network. Do you work more regionally and into nationally? So Sarah, for example, she has developed a rapid on-site evaluation service where when she biopsies a node, there is a biomedical scientist within the room who will look under the microscope to see if that biopsy is adequate and if there are cancer cells there. This is rapidly increase the speed of the diagnostic pathway. It's called ROSE, the Rapid On-Site Evaluation Service, and it's pinnacle. And so Sarah is spreading the word across the country on how to do that. I'm influenced internationally at the minute. I'm part of the European Society of Paediatric Radiologists, and we've just written a paper on the unintended consequences of AI. So think of examples of the level of influence that you're working and make sure that is clearly articulated in your job description. And just finally, it should be the best bit of your career, shouldn't it? But actually, you find that trying to get remuneration for your job role is really hard. What you need to think about is that don't get downheartened. It is a long road. Please don't take it personally. Remember, you are the only person that knows your job role. Other people that you need to influence don't, so think about that and put yourself in their shoes. Okay, I've learned from the experience. I am now trained in job matching, as I say, and I'm working in the independent sector on how job descriptions should be written. Now think about individuals as well. Okay, Jeff Bezos has got a great saying that if he can't feed everybody in the room from one pizza, a decision won't be made. So make sure you approach people individually and think about what their prerogative is. So consultants for us are our clinical supervisors. We are there to make their job easier. So therefore, you want to present your scope of practice to them or your clinical aspects of your job description and just get them to oversee it and say, are you happy with it? Are you happy to support me? Like somebody said earlier, it was the consultants that pushed the AAPE roll forward, and therefore it was accepted by other consultants. So think about that role there. Your service manager, turn it on its head. If you were going into your service manager saying, actually, I want to downgrade, I want less money, they would jump all over it, wouldn't they? So what you've got to think about is when you're going in asking for more money, you've got to think about where the money can come from, because I will absolutely guarantee you they'll say there's no money. So think about where the money can come from. So for me, as a reporting radiographer that does 33,000 images a year, if I don't do them, a consultant has to do them, or they get outsourced. That's an awful lot of money. We spend £250,000 on outsourcing to private companies. So potentially that's where the money could come from. And you also say, if I don't do my job, this is who has to do it instead of me, and they are more expensive than you. They then take it to a general manager. They will want a very succinct detail as to why the upgrade is needed. It may then need to go to the executives for sign off. Please don't take it personally if it sits on their desk for a long time. Just keep trying to gently nudge the PA to say, actually, can this be signed so we can take it forward? HR, notoriously difficult to access. They're often overworked. part-time, not enough staff, but they will absolutely want the policy and the procedures followed. So my advice to you is know your job matching policy, or know, even better if you've got one, your advanced practice generic JD and how you add into that. So we have developed one recently, and what we've done is that we can have a 10 to 20% variation, and we don't need to send it to job matching. As long as we haven't changed it massively, it will go through at the 8A or the 8B level. I would absolutely suggest that you know the job matching process, and I've put the reference there. And finally, you know, write a succinct job description. It should reflect what you do and make sure it reflects the needs of the organisation. That's really, really important. I would advise benchmarking to other job descriptions. So for mine as a consultant, as the plain film radiographer JDs came up on NHS jobs, I'd print them off to make sure I was matching them exactly. And that was absolutely perfect for what I needed, because when I went into the service manager and said, this is the job I'm now doing, I've progressed, I've got a PGD in chest and abdomen reporting, I've got a PGC in education, and I teach in both the academic and clinical forums. I've got a module, you know, as I've expanded, I've put it down and I've made sure it matches nationally. Because the reason for that is when I went in, she said, actually, you're too unique. If you went, I'd like to be able to advertise your job and somebody step into your shoes. And I had to say, actually, on the contrary, I have made sure that I've benchmarked and I'm exactly as a consultant radiographer is written across the country. And there's also nice examples, as somebody said earlier, in the education and career framework. And I have to say, ask your friends, your family and your colleagues to read your job description. As they start and finish, they should absolutely understand what that job role is, because actually clarity is everything. Okay, that's me done. Sorry, I think I've run a little bit over time. I'll just finish with some ideas for future AHCP roles that we've got going on in Cornwall. A big one is the first contact MSK practitioner. I'm working with them. We've got clinical supervision between each other because, as you can imagine, that role requires a lot of image requesting and image interpretation, and from my point of view, it's really good to know their patient pathway and where the patient moves on and what they would like me to say on those images. So it works really, really well. And I just want to say thanks very much, and I'm really, really happy to help any of you with your job descriptions and moving forward. I really understand how frustrating it is, and you feel really underappreciated and undervalued, but you're not. You're absolutely the future, and I'm happy to help at all at any point. And thanks very much for listening, and good luck. As some references.
Amazing. Thank you, Chrissy, for your perspective on England and a practice down in Cornwall. So thank you for that. And our final stop around the country is with Northern Ireland. So I would now like to introduce Sonia Blythe, who is going to give her perspective around being ANP in older people's medicine. So welcome to the floor, Sonia.
Hiya. Thank you for the invitation to speak today. I'm here to talk to you and give a brief overview of consolidating the advanced practitioner role into practice from my perspective. Sorry, I just can't see the next slide clicker. Like many times throughout my career, the adjustment to a new role is a daunting one, and becoming an advanced practitioner was no different. When transitioning into a new role, especially one that has never been done before, you want to run when you see the challenges ahead. During and on completion of my master's course, the system in Northern Ireland was very different to when I commenced the course, as I'm sure many of you can relate to with COVID. The service that my role was developed for was a direct assessment unit for older people, which no longer existed, and we as a service were moved out of the hospital in which we had worked for many years. So now not only did I have to introduce a new role into a service that didn't exist, but I had to help lead on the rebuilding of older people's services into our trust, as the footprint we once occupied had been cut by almost 2/3. With the horizon looking very bleak, I knew the skills that I had learnt during the course would come in useful, especially those developed during the leadership module. It was important with the teams to ensure open communication and instill motivation. To ensue trust at a time when morale was very low, it was important to delegate to all members of the team to ensure inclusion. With the rebuilding of services post-COVID, no one knew what the future held, but all we knew was we wanted to make things better for our patients. If there is one thing that nurses do daily, it is to manage risk, but never more so in the role as an advanced nurse practitioner. It is important as a leader to ensure that you're continually reflecting and learning to adapt to the needs of the service. And this can be successfully achieved by getting feedback from your patients and colleagues. There has been plenty of challenges into embedding this role at a system level, organisational and practice level barriers. Within our trust, the governance of the role did not exist. We did not have a minimum standard for the advanced practitioner title, and there was no minimum standard set by our organisation. At a practice level, there's a lot of frustration for our trainees as they cannot order radiology until they have completed their master's level course. Personally, for me, moving from a managerial post to an advanced practitioner's post, it was people's understanding now what my post entailed and know that I wasn't trying to be a doctor. I've heard a great term reference that we are mega nurses, not many doctors, which I love. There's been a lot of talk around the NMC recognising the role and the regulation of the title, which I'll not go further into. The lack of clarity when it is a new role into the trust can mean different people have different expectations of the role. Within our trust, our advanced practitioners on completion are 8As, and a lot of people struggle to understand that a clinical role can have an 8A banding. The biggest challenge for me that I found was around the understanding of the autonomous practitioner that this role should provide. This barrier has been overcome with time and people developing the confidence in the role by seeing what can be achieved. Every day, I still have to explain what an advanced nurse practitioner is. With a lot of titles out there, it is very difficult for our colleagues to understand, never mind the general public. I am sure there's one common trait that every advanced practitioner will have felt at some stage in their role is the imposter syndrome failure. What we often forget in those moments when we feel that we will be caught out, it is the accomplishments that we have achieved to date and the abilities that we have for these competencies and the accomplishments that we have achieved. There's no doubt there's been plenty of successes. We within the Trust have been able to establish an advanced practice forum for all of our advanced practitioners, not just nurses. So we have physios and paramedics within our forum. We have streamlined our reporting structure across the Trust for advanced practitioners, where our advanced nurse practitioners will report to the divisional nurse. We all have clinical supervisors, and in some areas they also have educational supervisors. With not every Royal College having an e-portfolio, we wanted to set a minimum standard within the Trust, and we have been able to develop an e-portfolio for all advanced practitioners to use. And governance of the role within the Trust was very important, so we led on the work for an advanced practitioner appraisal document for everybody to use. I suppose never underestimate the value that an advanced nurse practitioner role brings. We're experienced, motivated nurses. We improve the continuity of care for patients across the Trust. We role model holistic care, and we innovate with quality improvement and research. I suppose what advice would I give to any trainee advanced nurse practitioner out there? It would be to embrace the challenges. With the changing face of healthcare and lack of clarity around the role, it is our responsibility to guide and shape the future of advanced practice. Ensure to be flexible. You should continually seek to improve the service that you work within, and ensure to meet the four pillars of advanced practitioner role and look out for those opportunities. Remember to hold true the values of advanced practice. Remember your professional roots. We're complementing our colleagues, not replacing them. There is a role for everybody within healthcare. And don't underestimate the impact that you have as an advanced practitioner. Be aware of the impact that you have. Ensure to lead from the front, challenge accordingly, and role model. You're giving your junior colleagues the aspiration of career development outside the traditional managerial roles for career progression within nursing. Thank you very much for listening. I'm happy to be contacted via Twitter or via email and happy to accept questions. Thank you.
Super. Thank you ever so much for that, Sonia. Really, really interesting insights there. So I've got some time for some Q&A. What I would just like to do the posters again. So please to vote. We will be closing shortly after this Q&A session. So feel free to vote for your favourite poster. And yes, like I say, we'll be closing that shortly. Oh, now some questions, and these have come from the chat on the platform. So I am going to start with the Scottish presentation for Corinne and Margaret. With regards to unpreparedness for the AP role, how significant is finding, and was it a key or longest theme?
Did you hear
I'm really
that
sorry.
properly?
I didn't. Apologies. I didn't hear that properly.
Yeah,
No, that's okay.
I can.
So with regards to for the AP role, how significant was this finding in your piece of work? Was it a key or strongest theme?
I think you're asking how unpreparedness was. Yes, is that right? I think it was key.
Yes.
It absolutely led to people potentially following the wrong pathway, which then led to further challenges down the road. So there was the two bits of the formal education, and what we had also discussed is because you've got independent roles, your supervised practice doesn't always cover all eventualities. So you could still be caught in an area that you hadn't had supervised previously.
Thanks, Margaret. I'm going to ask a question now for Rhiannon. So how important is it that the nations and regions standardise their banding?
I think it is important because, as I said, I live in South Wales and I live on the M4 corridor. It'd be quite easy for me to go and work in Bristol. So I could cross different NHSs, different countries to obtain a higher banding. It's not something that I'm planning to do because to me it's not about money at the moment. But, you know, life happens and therefore you don't know, one day it might become about money. And therefore, you know, if we can have that standard approach, then at least it isn't that risk of losing staff because there's a better banding in a different health board or a different country or for whatever reason. I just think that, you know, it's then a clear career trajectory that if you progress into this role, you achieve this banding. And it's not, like I said, it's not about the money. Sometimes it is also about, you know, that professional respect that you get when you go into a different banding, because it is difficult. You know, I currently working within my role as a band 6, and it's really difficult to kind of go, because then I've got colleagues at band 6 nurse practitioners. So it's like that difficulty between, you know, what's within their job description and what's within my job description, because it's not clear.
Yeah, brilliant. Thank you, Rhiannon.
Fabulous. So now I've got a question for Chrissy. So this is from one of the delegates. They found it interesting to hear about AI research development. How do you think, how do we ensure that research is central to all AP roles in practice?
The difficulty is we are the converted, but actually it isn't, is it? It's really difficult to convince our employers, the people that essentially pay us, that actually research is really important. But if you find a really, really good research project, so for example, you look through NICE guidance. NICE guidance will always have research proposals or areas that research is needed. That's exactly where I looked. Child abuse is on the rise. Child abuse fractures are really, really difficult to diagnose, and it often results in life or death decisions for these children. And so once you get a really good research proposal that can make people's lives easier across the board, then you should be able to take it forward. And that's what I did. So my advice to be is find a meaningful research project, start with NICE guidance and go from there, and then try and embed it that way. But it is very, very difficult to do.
Fabulous. Thank you, Chrissy. And over to Colette.
So question for Sonia. How do you think you can keep up to date with developments in your practice area when staffing is such a challenge?
I suppose for us, we're very fortunate within the Belfast Trust to have a great structure for our education. We do work on an 80-20 balance where 80% of our time is clinical and 20% of our time is non-clinical. So within that, then we can do keep up to date with anything that we need to. So it's really good within Belfast Trust.
Good. So everybody will be moving to Belfast Trust now.
Wonderful. So if we've still got time for some more questions. So if we go back to Corinne and Margaret, there's a question from a delegate. How do we move past these systemic communication and gatekeeping challenges that you have identified?
I mean, Margaret will probably answer too. I think it's really important for us to tell our story, to tell people the experiences that we're having. I think conferences like this, I think getting that message out there of what it is exactly like for being an ANP in a primary care community setting, because people are not aware of some of these things that happen. I think the lady from Netherlands, this is going to stick with me, the quote that she said was, even if your voice is shaky, don't lose it. And I think as a leader and as a professional, we owe it to ourselves, we owe it to our colleagues, and we owe it absolutely to our patients and relatives to make sure that we are doing that. So I think we have to keep doing that and develop these evidence-based clinical pathways, and I think that's really important. And Margaret's probably got something else she would like to say too, I'm sure.
Purely to add that we need to send it through governance routes of the impact that it has on people's journeys, on pathways of care and potential delays that it can cause. Because as Corinne says, people don't understand what it's like if you're not working there. So we have to be the advocates for shouting about why it's important that we break down some of these barriers, that it's not just because it's tricky for the nurses, it's because it adds potential delays and potential harm to people's pathways of care.
Yeah, agree, Margaret. There's an increased risk there, isn't there, if the pathways aren't working seamlessly. Thank you. So, question again for Rhiannon. Do you think there's a lack of understanding of the advanced practitioner role?
Definitely, from a colleague's point of view to the public point of view. As I said within my presentation, I visited a lady the other day and she had absolutely no understanding. I'd walked in, I said, "Hi, I'm Rhiannon, I'm one of the advanced nurse practitioners." And it obviously just gone over her head. Now, You know, you can't start every one of your consultations with a, hi, I'm Rhiannon, I'm the advanced nurse practitioner, that means X, Y, and Z, because we already have the time delays that we have in work. We don't have time to add on that additional 5 to 10 minute conversation of explaining that I've gone through X, Y, and Z to call myself this role. And therefore, and then in terms of like colleagues, as it was mentioned this morning, advanced practice isn't a new phenomenon that suddenly just popped up out of nowhere. I've been qualified for 10 years. I've been did my 3-year training before that. I knew before I even started my training I wanted to be an advanced nurse practitioner. So it's not a new thing. But even people that you work with don't understand what that means. You go in and you say, oh, I'm the advanced nurse practitioner. They're like, all right, and what's that? Well, what does that mean? Okay, thanks. And then walk off. So I think that lack of clarity impacts working relationships. It impacts public in terms of that they don't understand what they're getting. And then it impacts infrastructure, because I have heard my colleagues that work in independent practices say that they've seen people and they come back the next day to see the GP because they don't trust them, because they're like, oh, I don't even know what she was. And that is a scary thing, because how much time is then wasted?
Yeah, that's very frustrating, isn't it? And makes you feel undervalued a little bit as well, doesn't
Definitely.
it?
Definitely.
Fabulous, lovely, thank you. So a question now for Chrissy with regards to the recently released COR Education and Career Framework. Have you, Chrissy, have you found that useful in the process of developing the consultant roles at your trust? Is it a route that you've established yourself before the publication of this?
Look how big it is. Sorry. It's absolute. It's exhausting. So I've got to show you it sideways as to how many trees came down in the making of this print. But so that is it, the 4th edition. Is it helpful? Yes, it is. It is, but I don't know, I'm a bit sceptical. I'm sorry if there's a lot of managers on this call, but what I don't want managers to do is use it as a tool not to give people an upgrade. Everything should be done on the merit of that job description and what it offers to the trust and what level that it offers it at. It's good to have the framework to benchmark again, absolutely yes, because actually are you all finding, for me trying to move up, there was so much, you couldn't see the wood for the trees, and to try and gain that clarity is helpful, and it's just rather large.
Fabulous, thank you, Chrissy. So we're out of time. I would like to say thank you to everybody for your very unique perspectives, your unique approaches to advanced practice and your experience. So thank you all ever so much.